So the next question is from someone who's had MS bladder problems for a couple of years, and their urologist suggested to them that they could try botox or nerve stimulation. So, Jalish, maybe you can tell us a bit about what those things are, and are they effective, and when do you bring them up? When is it that they become an option for people?
So really, we're talking about those eminently treatable conditions now. It's a question about when it's brought up, and of course, as before the discussion about treatment goes on, it's about how to evaluate these symptoms, and so the bare minimum, of course, is a proper history, so providing the symptoms that you have, and as was discussed earlier, problems with passing urine and incomplete bladder emptying might be missed from a history, and that's why having an investigation like a bladder scan will give you the sort of information that tells you about whether the bladder is emptying or not. And often having a bladder diary along with this would be useful because it's sort of a real-time assessment of the symptoms. So whereas when you talk to a health professional, it's often sort of recall about what's happened the last few weeks or months, whereas a bladder diary is something which is prospectively made, and so for 3 days or 5 days and nights, of course, you have a fairly good idea about how bad the bladder is. It also provides information about what's actually the fluid intake and what's actually being drunk. For example, if it's maybe 10 cups of coffee or tea, that's the time when it actually comes out. You might think about it and say that, look, last few days I haven't been drinking much, so you say that, well, I don't drink much of coffee or tea, but then when you actually write it down prospectively, there's a lot of surprises that come out. And so so it certainly isn't then starting, jumping straight to Botox in that case, and where you want to start talking about a sort of coffee and tea and fizzy drinks, and which are known to sort of irritate the bladder and make the bladder symptoms worse. There are quite a few individuals who've got bladder symptoms that are quite early on in MS. They find that just by addressing these simple factors, it's enough for them to sort of for control of the bladder, and often the need for tablets doesn't arise. So it's certainly worth sort of pursuing this option. We talk about exercises and sort of pelvic floor exercises. We think about these sort of exercises in people who sort of cough when they leak, when they cough or sneeze. But actually, if you're urgent, particularly urgent, what you do is you sort of squeeze your pelvic floor, and often it's the case that the urgency symptom tends to subside. It tides over a potentially embarrassing situation. It gives you some more time to actually reach the toilet, and so pelvic floor exercise is actually quite helpful as well. We've had a few women who've come back and said that their sort of Pilates and sort of core stability exercises, which they do for their sort of core stability, their truncal stability, actually helps with the overactive bladder symptoms. And I've had a few patients who've come by who said, actually, I really didn't need to come and see you because after I met the physio and I started doing the Pilates, actually my bladder is much better. So actually, especially in the early stages, when now that there's no more awareness about the bladder, people start realizing that the bladder is a problem. These are actually quite effective. There does come a stage where actually medications become important, and there are quite a few pills on the market, and it's sort of finding which tablet is most sort of effective. It's the group of drugs that are generally used are called anticholinergics, and they block proteins in the bladder wall. And individuals who take these medications find that their urgency improves. They find they go less often to the toilet. They find they get up less often at night, thereby improvement in continence. So overall, sort of a better control of the bladder. These medications do have side effects, such as a dry mouth. We talked about constipation, and quite a few individuals come back and say that, oh, my constipation is worse, and we need to move on to something else.
Right.
And so there are sort of side effects of these medications. Botulinum toxin Botox has sort of come up in a big way. I think if one were to go through Botox, it's been around for around 60 years more, so it has a very good safety profile, and for the bladder, there's been recent studies that have clearly shown that in individuals with MS, there is a benefit with regard to urgency, frequency, and incontinence after having Botox injections for the bladder. Now, whether one is suitable for these injections really depends upon the symptom profile. And of course, urodynamics is an invasive test where catheter is introduced into the bladder, and this test will tell if the person has an overactive bladder or not. And how the Botox works is it relaxes the bladder muscle, and by relaxing the bladder muscle, this overactivity subsides, and thereby that's how it improves with these symptoms. Now, because the bladder muscle is relaxed to such an extent, often the problem of passing urine becomes more and more.
Right.
And so some individuals find that they start retaining urine. So hence more so important that the bladder scan is done before the procedure, and all patients who have Botox injections by a urologist will be sort of taught how to self-catheterize, so that if the need were to arise, then this would be the option that's available, and then that person would start self-catheterizing. Unlike for, say, spasticity, where the injections are required once every sort of 3 months or so, the effect of Botox is actually much longer. And generally it's around sort of 10 to 11 months is the duration of effect of the Botox injections. This is good or bad, depending on how you look at it. The good thing, say, if you're not very happy with Botox injections, well, then it completely wears off after, say, less than a year. And then you do return to how you were before, but at least you don't have to worry about their residual effects. The bad thing, of course, is if you're doing well, you need to come back. But coming back means it's a procedure that can be done as a daycare procedure. At Queen Square, it's done with local anesthesia, so the person comes in, has the procedure, goes home the same day. And generally most patients tolerate the procedure quite well. I think it's now licensed in the UK from September 2012, so it should be a treatment that should be available throughout the country.
So you could get it anywhere. You wouldn't have to come to Queen Square or one of the big centres to get it?
It's become much more widely available now. So
right.
We have less and less people going into London to have it done, which is great.
And does it have to be done by a doctor?
It needs to be done by a urologist,
yes.
or
right.
a urogynecologist.
Right.
And of course the assessment is very important. I think the person needs to be assessed whether they're suitable or not.
Yeah.
I mean, it does involve putting a camera into the bladder, having a look inside to make sure everything is all right, and also injecting into the bladder muscle. And so it does require a doctor sort of to make sure everything is all right and the procedure is done safely and the person is safe.
So all these other options and bladder diaries and really understanding the nature of the problem and changes in diet and working on your pelvic floor, all of those things would need to be explored really first to see how much benefit they would deliver before. Is that how it works?
Yeah, and an awful lot of people might manage their bladders really well with, say, an anticholinergic and doing self-catheterisation for a long time. And whilst most people are very nervous about the idea of putting a catheter in, usually once they've learnt how to do the technique and they see how overnight their symptoms can change and improve, usually within a couple of weeks they're doing it quite confidently.
Well, I must say, I've never met someone who's looked forward to catheterisation.
No.
I have looked forward to many people who've come back to clinic saying that it's not a big thing, and it's transformed my life.
Yes.
And also, by learning catheterization, I think it opens up many options, say Botox, for example, or even antimuscarinics, where we would be reluctant to start on someone who's retaining urine. Once they're self-catheterizing, or once they're catheterizing, and the bladder is being emptied on a regular basis, of course, then you can offer many treatment options. So it does open up many options by having that.
You quite often get people that you've tried to persuade them for years to try and self-catheterize, and actually when they do, they'll come back and go,
Was that it?
Was that it? I wish I'd done that years ago. Yeah, I think I had somebody that I worked on for about 5 years, particularly for problems at night. For a lot of people, if they're not emptying properly and they've got lots and lots of getting up a lot at night, if you teach them how to self-catheterise and they self-catheterise before they go to bed, it can be the difference between getting up.
Yeah, and
5, 6
obviously the
times a night.
fatigue's less and everything. Life's just so much better if you've a good night's sleep.
Yeah, absolutely.
Sort of never say never. Then.
Never say never.
Well, I must say, I think it's one when I speak to the MS doctors about this. I make it a point to say that every consultation that it needs to be asked.
Yeah.
And also if someone, even to the urologist side, when I speak to them, I say that please don't discharge these patients, because it's very important that a person with MS is followed up on a regular basis. That person might be doing well, but then it might just take a relapse for things to sort of get worse. Or it might be that the person gets better in a remission. And so they get better and they no longer perhaps require an antimuscarinic or self-catheterization. And so persevering for say 5 years, and you do find the benefits of it.
But I think we got there in the end.
But I think from the patient's point of view as well, it's as long as they know they can come back, if they're not ready at that moment, they say, well, that's fine, you know, but I'm here when you do need me.
That's it. It's knowing that every patient is different. That we're all, you know, we might have the same symptoms, but they're different. And so it's kind of having the healthcare professionals realising that actually, you know, like you say, they may not be ready for it then, but just stay with it, and then, you know, might come back.
And it's making sure that people have got the right information in the beginning, because when you mention a catheter to most people, they're thinking that it's going to be the size of a hose pipe. And when you show them some of the modern little catheters, they'll go, oh, okay, all right, okay, I'll maybe try it.
I mean, some of the adverts are like it's sort of compared to, say, a lipstick balm, and so that's sort of how discreet it can be, actually.
And there's certainly an awful lot of choice out there.
Oh yeah, absolutely. And I know when I first started, it was one catheter, and that was all that was on the market. But now we're inundated with all different types of catheters, and there is a catheter to suit everybody. It doesn't matter what the hand function is, what mobility is. We can usually teach most people.